realize.
A very good evening, everyone. Welcome to the iFocus online lecture 480 of the Refractive Surgery module. Today, we have the respected Dr. D. Ramamurthy, sir, for the class on phakic intraocular lenses, patient selection, and surgical procedure. For the session today, I would like to introduce our moderator, sir, Dr. Tushya Om Prakash, sir. He is the CEO of Dr. Om Prakash Group of Eye Hospitals, Punjab, with key field of interest in cataract and refractive surgery, keratoconus, and dry eye disease. Sir has numerous achievements to his name, including the Best Video Award in Cataract Surgery at IIRSI Delhi 23 and DOS 2024. Sir has been awarded gold medal for his exemplary work in ophthalmology by Bombay Ophthalmological Society. Also the best paper of the session at APACRS 2019 at Kyoto, Japan. Also the recipient of various prizes for video representations in many conferences around the world. Academic and professionally, Sir has also organized and led instructional courses at international conferences including AAO, ASCRS, and ESCRS. Sir has performed live surgical demonstration, cataract and smile at various national conferences. Sir has also contributed chapters to various ophthalmology textbooks and have more than 12 publications. Sir has been inducted as a reviewer for the International Journal of Clinical Ophthalmology. Welcome, sir.
Thank you.
I would now like to introduce the chairperson for the session, Dr. Gaurav Luthra, sir. Sir is the director and head of Drishti Eye Institute, Dehradun. Sir has a special interest in refractive surgery, challenging adult and pediatric cataract surgeries, and keratoconus. Sir has also been the chairman of academics and past president of Intraocular Implant and Refractive Surgery Society of India. Sir has been the founder member and honorary fellow of World College of Refractive Surgery. Sir has been awarded Honorary Fellowship FAICO in Refractive Surgery by All India Collegium of Ophthalmology. Sir has demonstrated over 200 live surgeries and has 5 orations and 4 named national awards to his name. Welcome, sir.
Thank you.
Finally, I would like to introduce the speaker of the session, Dr. D. Ramamurthy, sir. Sir has done his MBBS from Jipmir, Pondicherry, and MD Ophthalmology from RP Center, AIMS, New Delhi, followed by a fellowship at Shankara Nethralaya, Chennai. Currently, Sir is the chairman of the Eye Foundation with key areas of interest in cutting-edge technology in cataract and refractive surgery. Previously, Sir has also been the past president of AIOS and chairman scientific committee for a period of 6 years of AIOS. Sir has been awarded 26 named orations both in India and abroad and has been invited speaker and has performed live surgeries in most parts of India and several countries abroad. Sir has over 67 publications in peer-reviewed journal. Sir also has numerous awards to his name like the Asia Pacific Certified Educator Award by the APACRS, Distinguished Service Award by APAO, Senior Achievement Award by APAO. Sir has also been elected as a member of prestigious IIIC, which is the International Intraocular Implant Club, and Sir has also received an achievement award by the American Academy of Ophthalmology. Welcome, sir.
Thank you. Thank you.
I would now like to invite the speaker, sir, to share the slides and start the session.
Thank you. My slides are seen?
Yes, sir.
Thank you so much, Dr. Garvita, for this such a kind introduction, and thanks to iFocus and Center for Sight Group of Hospitals for this gracious invitation. I do acknowledge the presence of my two very good friends, Dr. Gaurav Luthra and Dr. Tushya Prakash, for joining today evening. Looking forward to a great learning experience and good interaction. I know that all my other colleagues who are in the panel are also extremely proficient surgeons, and look forward to good inputs from them. So I'll be talking about phakic intraocular lenses, patient selection, and surgical techniques. Basically, I have divided my talk into this following structure, in the sense that basics and introduction, then how exactly I select patients in my practice for phakic intraocular lenses, preoperative workup, and then the surgical steps. So As far as the basic principle of a phakic intraocular lens is to place an eye with a normal crystalline lens in place, essentially to correct extremes of refractive error or where corneal refractive surgery is not possible because of an inappropriate cornea. Looking at the requirement for this particular procedure, if you see over here, this is a fairly old paper published way back in 1997 in Australia, where when refractive surgery was still in its infancy, and but gives an idea of about what exactly would be the relevance of refractive surgery. Low myopia in that general population was just about 20% of the population had low myopia, which was 0 to 5 diopters. Just 2% had 5 to 10 diopters, while high myopia constituted just 0.4% of the total population. And in the myopic population, they constituted just 2%, while low myopia constituted 88%. But when it came to persons presenting for refractive surgery, essentially 13% of the refractive surgery patients belong to the high myopic group, that is beyond minus 10 diopters. Obviously, this numbers as far as general population and myopia will vary widely. In the southeastern population, in our own population, the prevalence of myopia is much higher. And again, the prevalence of high myopia will also be higher. So obviously, though high myopes constitute a smaller percentage of the total number of myopes, the propensity for undertaking refractive surgery is much stronger in them simply because they are the ones who are likely to benefit the most. And it's not just a cosmetic surgery for them, but it's a life-changing procedure. And essentially, the motivation for getting myopia refractive surgery done in moderate myopes is supposed to be almost 10 times more likely than in low myopes. And when it comes to high myopes, that is beyond minus 10 diopters, it's likely to be almost 16 times more. I think it would also translate to similar numbers when we talk about higher grades of hyperopia, which can be quite disabling, in which case a clear lens extraction might be the way to go. And as I already mentioned, when it comes to high grades of refractive error, like this particular patient that you are seeing here, is not just as something cosmetic, but the high grades of refractive error is disabling, something like keratoconus itself. So sorry. It leads to lack of self-confidence, social isolation, relationship difficulties, even difficulties in getting a job. And once you are able to correct them, it's not just the quality of vision that you are changing, but it's a life-changing intervention. And when it comes to phakic intraocular lens versus laser vision correction, the impact of the phakic intraocular lens is significantly higher. And the expected benefits of this procedure far outweighs the risks that we'll be seeing in the slides to come. What exactly is the risk of laser vision correction when the patient presents to it with high grades of refractive error? The risks are that there can be harder undercorrection. The higher the grades of refractive error that you are correcting, even though you might get immediately quite good success over a period of time, it tends to regress and certain amount of refractive error tends to come back. I have been doing refractive surgery right from 1997, laser vision correction. That's all more than 25 years. And I almost have started believing that refractive laser vision correction has a certain lifetime. Patients who did very well 15 years, 20 years are presenting to us now with even a diopter and a half, 2 diopters of residual refractive error, even though they might have been corrected just for about minus 6 diopters. Fortunately, some of them are entering the presbyopic age group, so the residual refractive error tends to help them. But having said that, that's something quite unacceptable. And then many of these patients are looking for something to be done for the refractive error, which they thought was corrected for their lifetime. Then, of course, once you are correcting significant amounts of refractive error, even if you leave behind adequate amounts of refractive corneal tissue, there are greater risks of corrected ectasia. And even if you're using an aspheric mode of laser vision profile, basically there are increased optical aberrations, especially spherical aberrations, which deteriorates the quality of vision, causing dysphotopsia. The amount of spherical aberration induced by the refractive correction is directly proportional to the amount of refractive error that we are tending to correct. So obviously, if we are correcting higher grades of myopia, then there's a significantly more spherical aberration that will be induced. And then there could also be loss of best corrected visual acuity, especially if you're correcting hyperopia and you're leaving behind a hyperprolate cornea. Chance of dry eye is also become significantly more if a higher grades of refractive error is getting corrected. The advantage of phakic intraocular lenses in these situations would be that there is no corneal tissue removal, and whenever you are not touching the cornea, the quality of vision that the patient is left behind with is significantly better. And since it's easy to take out a phakic intraocular lens, it's a reversible procedure, even though it's rarely ever required. But it gives you confidence that in case the patient is not happy with the procedure, you can leave the patient behind with whatever we started out with. And because the cornea is left untouched, and what the patient gets on the first postoperative day is what remains with the patient for the rest of the lifetime, but at least till the onset of cataract, it's better quality of vision that the patient has, and fewer aberrations in dysphotopsia, and avoids potential side effects of laser vision correction, including induced dry eye, as I already mentioned. What are my indications for phakic intraocular lenses? It is beyond -8 diopters. Now I put it even beyond -6 diopters. -6 to 8 diopters is a gray area for me. Anything beyond 5 to 6 diopters, I always tell the patient there is an option of phakic intraocular lens also. Anything beyond +2 to 3 diopters, then I definitely tilt towards phakic intraocular lenses, especially in the presbyopic age group. And beyond 3 diopters for astigmatism, definitely phakic intraocular lenses would be a consideration. If I have to do laser vision correction between 470 to 500 microns, is essentially what I go to is a PRK procedure, maybe PRK or PRK extra, depending upon the corneal condition. Anything beyond 500 microns is when I go for SMILE or a femtosecond based procedure. And if a patient says the quality of vision is extremely important to him or her, often has a long conversation about that. Even if it's a 4.55 diopters, then I do tell them that a phakic intraocular lens is a choice where the deterioration in the quality of vision might be significantly less. Again, if the patient is asking about lifetime guarantees, etc., I do inform them, even for lower grades of refractive error, that you could consider laser phakic intraocular lens, because I am confident that what I leave behind in the eye, especially in a patient who is 21 years or beyond, is likely to remain with the patient for till the onset of cataract or presbyopia. And then we have to remember, as one of my subsequent slides will show, a laser vision correction and phakic intraocular lenses are not competitive but complementary technologies. And in case there is a residual error that's left behind after a phakic intraocular lens implantation, you could deal with it with laser vision correction subsequently. I'm sorry. And as far as the contraindications for phakic intraocular lens is concerned, it is myopia other than axial myopia, especially if you think it's index myopia. If the refractive error is progressive, especially if in patients between 18 to 21, laser vision correction is something I offer for patients beyond 18 years. If the refractive error has been stable for at least a year, in case of phakic intraocular lenses, I tend to wait up to the age of 21. And in case there is corneal dystrophy or endothelial cell count is less than 2,000 cells per cubic millimeter, then again, phakic intraocular lenses is a contraindication. If the anterior chamber depth is less than 2.8 millimeters, for me, it's a strict contraindication, though there are surgeons who stretch the limits now, and even up to 2.6 millimeters, they do consider, maybe this will come up during the discussion. If there's history of inflammation in the eye, presence of anterior and posterior synechial glaucoma, angle pathology, angles which are less than 20 degrees, nuclear sclerosis or developing cataract, obviously, whenever there is pathology in the eye, apart from the basic refractive error, I would tend to stay away from doing a refractive surgery. Significant retinal pathology like compromised macula, very poor periphery with retinal tears, multiple retinal lattice, etc., which have, even though they might have been treated with peripheral barrage, is a relative contraindication for a phakic intraocular lens. Another significant advantage we must understand in phakic intraocular lens is that the effective optical zone of a phakic intraocular lens, because of the proximity to the nodal point of the eye, is to 1.25 times the optical zone size. That is, if you place a 6 millimeter optic phakic intraocular lens just in front of the natural lens, then effectively what you get is a 7.5 millimeter optic zone. It's almost like having a 7.5 millimeter optical zone correction on the surface of the cornea, because of which you get a greater quality of vision and lesser induction of spherical aberration in these cases. As I already mentioned, laser vision correction and phakic intraocular lenses are complementary and not competitive technologies. Oftentimes, we debulk the significant amount of refractive error with a phakic intraocular lens. Then 3 months out, we do a laser vision touch-up on the cornea. Up to minus 27 diopters or 4 diopters of with 4 diopters of astigmatism, we have treated by combining these two technologies. And combination of these two technologies enhances the benefits of these two without increasing the risk that these pose when handled with individually. As far as preoperative workup itself is concerned, these are Gaurav and Tushya, would you like to have some comments in these slides, just in case you would like to, or should I go on?
So you can go on, sir.
Okay. I just wanted to chip in by saying that amazing slides. And the only thing that has changed is that when we started off doing ICLs about 20 years back, we used to consider 18 years as the cutoff. And that I rightfully said that today we don't consider 18 as the cutoff. And, I would rather wait for 21, 22, or even up to 25 for, the chamber depths and everything to stabilize, the refraction to stabilize. Because I do remember one patient where we did a, young guy who was very keen with about minus 10 or 11, minus 12. We did his surgery at the age of 18. By the time he was 21, 22, his axial length had increased, and so had his vault went down because there was some increase in probably the ciliary sulcus. So not only can the axial length increase, but even the vault of the ICL can go down. And in fact, I had to explant that lens by the time the boy was 25. So today I like to defer this thing. Otherwise, everything else, of course, Dr. Ramamurthy has covered almost everything.
Thank you. So as far as the preoperative assessment is concerned, I think these are the most important aspects that you would look into. One is refraction, especially the objective and subjective acceptance at 12 millimeters vertex distance, because this is essentially what you're going to order the lens with. The anterior chamber depth measured from the corneal endothelium. I'd be dwelling a little bit on this. And the white-to-white measurement is extremely important because that determines the sizing of the lens that you place. Apart from that, the other features that you are obviously going to look for is the topography. In case there's a significant cylinder, you have to make sure that's something which is regular. It's either a horizontal bow tie or an oblique bow tie, and it's correctable with spectacles, and the patient does not need a semi-soft or a rose-scale lenses for correcting the astigmatism. The intraocular pressure should be in the normal range. A good examination of the anterior and posterior segment, especially since majority of these patients are eye myopes. A good examination of the posterior segment is extremely important. A good endothelial cell count and a pupillometry is again something which is extremely important. Accurate acceptance. Subjective acceptance is what we go with, and an accurate estimation of the cylinder and the torics is also important, especially if you are handling hyperopia. A cycloplegic refraction becomes of paramount importance. Regression in cases of hyperopia is more because of not enough manifest hyperopia being corrected, rather than the hyperopia itself increasing. And consider the back vertex distance. Make sure that it's at 12 millimeters distance, and preferably, even though it's not as mandatory as corneal refractive surgery, I preferred my patients to be off contact lenses for a week before estimating the amount of correction that the patient needs. And just in case, most often I do my phakic intraocular lenses through a temporal clear corneal incision, but just in case the patient has about a 0.5 to 0.75 diopters of with the rural astigmatism, which is often prevalent in this age group, then I tend to go towards a superior incision and implant a spherical lens, maybe for cost considerations. Of course, make sure that the lens is finally oriented in the 180 degrees axis, that is horizontally, but then I would introduce the lenses through the superior incision, because a 3 millimeter superior incision has the propensity to control about 0.5 to 0.75 diopters of astigmatism. As I already mentioned, an anterior segment OCT I consider is of paramount importance. You do not, even if you don't have a AS-OCT access, you can estimate the anterior chamber depth, and it's most important to understand that it has to be estimated from the endothelium, because many of the instruments have as a default setting estimates it from the epithelium, in which case you can either change the setting or minus the corneal thickness, and then it has to be 2.8 millimeters or above. Lens rise is another thing that we have started looking at, where you have this horizontal plane at the level of the iris and how far the lens is protruding in front. As Dr. Gaurav just mentioned, sometimes these lens rise can increase over a period of the lifetime of the patient. Again, if the lens rise is quite significant, those are the cases where you would strictly stick to the dogma of 2.8 millimeters anterior chamber depth. In case the lens rise is less, in the negative, that is below this horizontal line, these are the considerations where some surgeons think that they could loosen up and then go as far as 2.7 millimeters. But if you're especially starting out with phakic intraocular lenses, it's always a good idea to ensure that the distance between the anterior corneal anterior capsule and the corneal endothelium is 2.8 millimeters or more. And we would dwell in the other aspects. As I mentioned, what we are looking for, what is the difference between the posterior surface, the phakic intraocular lens, and the anterior surface, the lens is called the lens vault. And this should ideally be about 500 microns. The range is said to be classically 250 to 750 microns. And you have a ready reference by the way of the corneal thickness, which is usually in the range of about 500 to 550 microns. The vault and the corneal thickness should be almost similar. And as I already mentioned, the sizing essentially depends on the horizontal white to white. But the other consideration, as we'll see in the subsequent slides, is the anterior chamber depth as well as the keratometry. And the nomograms that the companies use for sizing the phakic intraocular lenses is essentially a combination of all these three factors. A digital calipers used appropriately is an excellent way of determining the white to white. And very often I do have a digital measurement as well as an instrumental measurement and make sure that they line up together. And it's important that you make the patient lie down, do it under the microscope, put a drop of anesthetic, and then take the white to white measurement with the, and then you could even read the calipers measure on a ruler. Most importantly, you must understand that the limbus is not essentially a line, but a zone. And what you have to do is to take the measurement from the middle of the limbus, not from the sclera, not from the cornea, but essentially in the gray zone, which this is the area where you would measure from this. And that essentially is extremely important as far as the sizing of the lenses is concerned. You have the OpScan, the Pentacam, the Topolizer, and various other, even some modern autorefractometers, which could give you a white-to-white measurement. Anything like an IOL master, which uses the laser interferometry principles, essentially does not measure from limbus to limbus, but measures from sclera to sclera. So they tend to give almost a 0.5 millimeters more. So they are suboptimal instruments as far as the measurements of the white-to-white is concerned. Just in case you have a pterygium or a finger pigmented nevus right at the limbus in the 180 degrees axis, this could be incorporated in the measurement instrument, and they might give a slightly raised white-to-white measurement. That's the reason that I always measure with the calipers also, and I'm more comfortable when these two are almost coinciding. And just in case there is a significant difference, then I go back again on the slit lamp and then determine what are the reasons that there is a difference. And both eyes of the same patient should always have nearly the same white to white. And in case there is a difference between the two eyes, then again, that's something you need to look into and more carefully. You have to understand that the white to white corresponds with the angle to angle measurement. And the size of the lens that we implant is usually about 1 to 1.25 millimeters more than the white to white. The sulcus to sulcus measurement, which could be determined some of the modern UBM, is 0.35 millimeters on an average more than the white to white. The sulcus to sulcus measurement might be thought to be the right way to go because that's where the lens often sits. But most of the phakic intraocular lenses that are dispensed to us, that are given to us, the manufacturers base it on the white to white measurements. And that is the reason that most of us still stick on to white to white. But though artificial intelligence-based formula are also coming into consideration, maybe we'll take it up during the discussion timing. The reason we want to be extremely accurate as far as the phakic white-to-white measurements are concerned, as you can see over here, even a 0.1 millimeter difference in the measurement could translate into a change in the diameter of the measurement in the diameter of the lens to be implanted by about 0.25 millimeters. In case you are using a ICL, which comes in a jumps of 0.5 millimeters, that is 11.5, 12, 12.5, 13 millimeters, it could translate to a difference of about 0.5 millimeters. So obviously, that could cause a significant difference in the vault. The size of the lens that's implanted is 1 millimeter more than the white to white. If the AC depth is between 3 to 3.5 millimeters, the size of the lens ICL becomes less by about one step. It's less than 3 millimeters anterior chamber depth. If it is more than 3.5 millimeters, the size increases by about one step. It's logical because as if you have a smaller eye with a shallower AC, you tend to implant a smaller lens. If you have a deeper anterior chamber, obviously you will go with a larger lens. So you have to be extremely concerned about the AC depth, especially if you're considering a high-powered lens, say a -18 diopter or a +8 diopter phakic intraocular lens with also significant amount of astigmatism thrown in, simply because these lenses tend to be thicker in the periphery. Very often you are tempted, these patients are extremely motivated to get a refractive surgery done, and then there's no other way that can be addressed in a, say, -18 diopters with 3 diopters astigmatism. You're tempted to offer to these patients, but you have to remember that these are the patients who run into trouble in case the AC depth is compromised, because these are the patients where the plano-concave lens as well as the biconvex lens, hyperopic lens, tend to become thicker in the periphery, and then these could create problems in the postoperative period. As far as the sizing in ectatic disorders is concerned, whether it's keratoconus or iatrogenic keratoconus, if the cone is well stabilized and the power is correctable in the postoperative period by spectacles, because the cone is well centered, you could consider a phakic intraocular lens. In these cases, once you have gained enough experience with these lenses, what you have to remember in these cases is that there could be a central cone over here. It's not like a normal eye that you are dealing with, like a 3 millimeter AC depth, but there could be a 3.5, 4 millimeter almost in the central area. But there could be a peripheral crowding. So essentially, what is recommended that you take measurements in multiple locations, including the periphery. But obviously, in these cases, there are not adequate nomograms to tell you what exactly would be the sizing depending on the peripheral AC depth. So what we usually do is in these cases to go about 0.25 millimeters to 0.5 millimeters less in the sizing of these lenses, especially if there's a central significant cone, and it seems to work out quite well. As far as the designs of phakic intraocular lens, any comments or should I pass on?
So I think you can go on, sir. It's quite clear what you told us.
Okay. Very quickly, basically, you have the ICL from Star, and now there are excellent Indian companies also which come up with good alternatives. We have significant experience with the ICL, with the IPCL, which is from the IOCare group, and with the biotech group, ICRIL lenses also. And these, in my hands, all these three lenses seem to work quite well. No financial interest whatsoever in any of these companies. But suffice it to say, for the sake of, in the ICLs, you have +10 to -18 diopters power range. And in the IPCL as well as in the ICRIL lenses, you have almost from +15 to -30 diopters. Up to about 6 to 8 diopters astigmatism can be corrected. I used to be, when initial experience was all with the Collamer material of the ICL, and when I was shifting over to the Indian lenses, my consideration was whether the Collamer, being the most biocompatible material that's available, placing these hydrophilic acrylic lenses in a young patient in the sulcus would be a good idea. But now that we have significant experience with these lenses, more than a decade, and we believe that these lenses, with the material which is very similar to what is used with our hydrophilic intraocular lenses, is quite stable and can be taken into consideration for placement in the sulcus also. All these lenses come with a central hole, which is 360 microns or 400 microns, because of which there is no need for a peripheral iridotomy. The haptic pads, you can either have 4 pads, and the IPCL especially comes with 6 haptic pads, as you can see over here, which the manufacturers claims that offers better stability. But in my hands, if the sizing has been right, either of these lenses, or for that matter, all 3 lenses remain quite stable. And one of the differences between the ICL and the IPCL is that the ICL, especially with the toric question, you have to often dial them into place, because the final resting place may be at 10 degrees or 5 degrees. While the the TIPCL is more often customized, because of which you can leave it in the 180 degrees. And as you can see over here, the ICL, is the leading right edge. Somehow I'm not getting the arrow over here. The leading right haptic, and the trailing left haptic, which has a small hole, while the stud over here is in the leading left haptic by the side of the leading left optic and the trailing left optic. So you have to understand that and position the lenses accordingly. The lenses are dispensed in BSS in ICL, while it's in saline in IPCL. In both these, they do not expand after implantation. So most often the profile that you get, or the wall that you get on the immediate postoperative period, is what the patient is left behind with. As far as the loading is concerned, it's a little different with the ICL, while it's in the case of a IPCL, is very similar to a plate haptic intraocular lens, so that if you're, say, familiar with loading a plate haptic intraocular lens, you would very easily adapt to this. And as the optic size itself, the EVO ICL, which comes up with a slightly larger optic size, comes in the range of 5 to 6.1 millimeter, while the IPCL comes in the range of 5.75 millimeters, 6.2 millimeters. In case you have a very high scotopic pupillary size, you can even customize the Indian lenses. And as far as the overall diameter is concerned, it comes in the range of 11 to 13 millimeters or 13.5 millimeters in the ICL, in jumps of 0.5 millimeters, while the Indian version comes in jumps of 0.25 millimeters, which to my mind is a bit of an advantage when you want accurate sizing. Very quickly, coming to the surgery, I want to give enough time for discussion, because there are 2 eminent people who can also contribute very significantly. One of the basic things that we have to understand, that anybody who can do good phacoemulsification, good anterior segment surgery, can easily incorporate this. And one of the advantages of these lenses is that though the lenses are reasonably expensive, you don't have need to have access to expensive technology like which is required with laser vision correction or with Atlex procedures. But one important feature that you have to keep in mind is that when you are talking about cataract surgery, essentially what you are most concerned about is the posterior capsule and the corneal endothelium. And once you take the lens out, you have almost 8 millimeter space in a normal eye. While in a case of a phakic intraocular lens, all your maneuvers have to be limited between the anterior capsule and the endothelium, which is about 3 millimeters or less. And because of which, whether it's the angle of the anterior chamber, the corneal endothelium, the anterior capsule, all your maneuvers have to be extremely guarded so that you do not damage these extremely delicate structures in any way. And that's something that you learn with time. Coming to the surgical procedure itself, I have edited video, just a couple of them. As you can see here, this is the methyl cellulose being injected. I always know that, and this is the ICRIL lens that's being taken out, and you can see that the leading left optic had the small hole, and it's a trailing right haptic which will have the hole. So exactly opposite to what is there in the ICL. And as I mentioned, the loading is exactly similar to what we see with the plate haptic intraocular lenses. And you have to make sure that the optic of the lens doesn't get caught between the flanges. It's a front loading cartridge that comes in. You gently insert the lens and then subsequently move it forward so that you have to make sure that's in the essentially, I'm sorry about that. No, I just wanted to make a comment here in the sense that I do not dilate my pupils before surgery because as you can see over here, I start my surgery without the patients being dilated because all of us have experienced a very, very occasional trauma to the anterior capsule when you're making a side post main incision during cataract surgery. Obviously, in those cases, we incorporate them in the capsular rhexis. But in case this happens in a phakic intraocular lens, obviously that's an extremely significant trauma, and you could end up with a cataract. So essentially, just as a matter of abundant caution, I do not dilate, and I find that in these young patients, the pupils tend to dilate with just intracameral lidocaine with phenylephrine. And so you can see the pupil has not been dilated, and I place my incision at 180 degrees. Rather, I'm seated temporally. So essentially, it's at the 6 o'clock and 12 o'clock meridian. The incision I make is essentially is a 3 millimeter incision because it's not wound assisted implantation already. And as you can see, I'm using high molecular weight viscoelastic. That's something like Helon GB, and the intraocular lens is injected in a very controlled manner so that it opens up the right way. And you can see that it's always injected in front of the iris, and then subsequently it's gently tucked in behind the, this is the only extra maneuver that you need to learn from your anterior, from your cataract surgical procedure. It's extremely doable. And if you do not have access to a digital device, then you can always use a manual marking. As you can see, I do not use a irrigation aspiration. As I hydrate the main port and the side port, the cohesive viscoelastic tends to flow out and as a single block. And as I see clear fluid coming out, I know that the viscoelastic has been completely evacuated. So I think that's the reason I do not dilate my pupils. I use a cohesive viscoelastic. So the maneuvering is extremely simple. So this video lasted just about 2.5 minutes, and it has been edited, but the total time taken is just about 4 minutes under topical anesthesia. And whenever I'm doing bilateral, which is most often, I immediately change my gloves, change my gown, different sister and different center set of instruments are wheeled in. Go ahead and address the other eye with a extra set of instruments. And going ahead to the next video, here we are actually implanting an ICL, almost a similar procedure, but here loading of the ICL is something that you need to learn. And initially, when we started out, we were told that 50% of the phakic intraocular lens is loading. But once you have done a few lenses, you get quite comfortable with that. Actually, in my theater, it's the sisters who load the lenses on a side table with the illuminating device or fix it onto the table. And as you can see over here, it's again viscoelastic, which is loaded in. This is dispensed in a balanced salt solution. you pick it up with the stick, ledger that is dispensed with with the lens, and you have to make sure that that the ICL is placed properly, and then using a front-loading forceps, you gently draw the lens forward by pulling the cartridge back, and then subsequently you go on to the surgery. As you can see over here, again no dilatation, and the side ports are made, which is about 1 millimeter in size. And this is what I was saying. This is phenylephrine and xylocaine mixture that goes in after my main port incision is made. Actually, earlier what I was introducing was just saline to make my eyeball tense. And it is only after I made the main port incision also that I introduce the dilating mixture. And then subsequently cohesive viscoelastic goes in. And this is the phakic intraocular lens that's being introduced into the eye. And as you can see over here, the lens, you have to make sure that the lens is opening up the right way by keeping an eye, in a case of an ICL, by at the leading right haptic to make sure that the hole is there. Then gently is tucked in. You do it in an extremely atraumatic fashion and do not touch the central optic, which is quite thin. And as you can see over here, I do just hydrate the main port and the side port, and you can see the cohesive viscoelastic flowing in as a blob. And once I see clear fluid flowing out, I immediately know that the entire cohesive viscoelastic has flowed out. And even though there were initial concerns about viscoelastic getting retained behind the lens, practically I've seen this not happening. It's almost 3 years since I've switched over to this way of implanting these lenses, and as you can see, and this seems to work quite well. This is a non-toric lens, but more than 75% of my cases are toric phakic intraocular lenses, because in these cases, you do not want to leave behind any amount of astigmatism uncorrected. I know there will be a subsequent speaker in another session who will be dealing with complications, complex situations, but just a couple of quick references to situations that you will come across. In case the phakic intraocular lens doesn't seem to be rightly oriented, then especially if the spherical equivalent is of the residual refractive error is almost zero, I go in with the irrigation cannula. No viscoelastic is used. And as you can see, it's just a 2-minute procedure to orient the lens in the right way. And it's something that you owe it to your patients to do it. I think I'll skip the cataract surgery part and vaulting, etc., because that's going to be complications. I think I stop my presentation here with the conclusion that in our quest for ideal refractive correction, phakic intraocular lens is a very useful tool. And I think for a modern day refractive surgeon, incorporating this into his armamentarium is extremely important. Thank you so much for your kind attention. I think we'll hear it from the other panelists as well as if there are any questions.
Thank you so much, sir. That was an excellent presentation. You had covered all the aspects, and I'm pretty sure that the audience here must have learned so much today. So, as just wanted to ask a few things to Dr. Gaurav and yourself. That so, do you what are your like preferred way of calculating white to white, Dr. Gaurav? Like, because I've heard like you've been using a lot of AI tools, like for example, like Dr. Dan Reinstein's ICL sizing, ICL Guru. So, what like how can we predict what by what is the correct way of calculating the right size for the ICL or Phakic IOL?
So I think Dr. Ramamurthy, you want to go first? He's
No, no.
actually, so I'll go first then. So, basically we've been using white to white, and that's how Star actually got the FDA approvals. And when the first approvals came, it was based on AC depth and white to white, and they had 4 sizes, which we continue to have today. And they had actually done their studies on the OpScan. And the white to white, which was used for those FDA trials, was basically from the OpScan. And they also did specify about the manual measurements and maybe from the digital calipers, but they had also mentioned in the same FDA approvals that they felt that ciliary sulcus to sulcus might be a good option to do because it's more accurate, but they didn't have the means to do it. And the B scans, I mean, the UBMs at that time were not, in that league. So frankly, over the years, we've all used this, but today if we have, you asked about how to measure white to white, I think digital calipers is the best way to do it. But now we have very good objective devices as well, which kind of correspond. And in fact, we had a poster which was appreciated in the ESCRS about 2 years back, where we compared 4 devices, which included the IOLmaster 700, the Lenstar, and the Pentacam. And I think it was the iTrace for the white to white. And in that study of about 200 eyes, we found that the Pentacam came closest to what we were getting with the digital calipers. And that's why we tend to use the Pentacam most, because the 700 tends to kind of, so there's a big difference between the 500 white to white and the 700 white to white. They don't correspond with each other. I mean, there's a skew, there's a fixed difference between the two. So you have to know which objective device you're using and then find out the fudge factor basically by which it is differing from your digital calipers. And then, but Pentacam and digital calipers tend to be interchangeable. Now, this is as far as measuring the white to white goes. But going beyond, your second question was to ask about use of AI and other tools. So essentially, those tools are all boiling down to two methods. Either you can do the sulcus to sulcus measurement using the UBM, because the OCT cannot penetrate behind the iris. So, and again, the UBMs, you cannot just use the standard. We did a demo of 3 UBMs over the last 7-8 years, trying to think that we'll be able to get sulcus to sulcus measurements. But invariably, there was no consistency and objectivity between those UBMs even the same person measuring the sulcus to sulcus on 2 different occasions would get different readings. So how Dan and in the ICL Guru by this guy, what's his name? By Zaldivar, what they've done is that Dan uses the ARC scan, basically, which is supposed to be the highest resolution, and they are able to get, it's a little tedious and it requires a path and everything, and it's more kind of intensive, but it has an objective way of measuring the white to or the sulcus to sulcus with the ARC scan to a very high accuracy, and which is reproducible. Similarly, Zaldivar has done it for 3 devices. He's done it with the Sonomed and 2 other UBMs, which they are also higher versions of the UBM. They are not the standard UBMs that we tend to use, and they all have built-in tools for image capture and measurements and interpretation using artificial intelligence using a software, which is ICL Guru. So that is as far as the UBM goes, and then you can have a vault prediction. And the new thing in this thing is vault prediction, and all these machines tend to give you a vault prediction with different sizes of ICLs. I have been using OCT-based AI tools, and I'm using the one which was being developed by Alan Sard and Damien Gatinel, and that's on the Anterion. And there are others which are on the Cassia and also on the IOLmaster 700, and they all use the lasso technique for the ICL calculation, and they do give a vault prediction, and we are now routinely using that, and it's very useful. So if anybody has a device, either the 700 or the IOLmaster 700 or the Ativo, or I mean the Anterion or the Cassia, they have the lasso models for those particular formulas, but they are not interchangeable. So I mean, it's a long one, but then that's how the thing is evolving. And today, when I operate, I have predicted vaults for all my ICLs put up on my OT table. And I also ordered 2 ICLs of 2 different sizes. And I also use the intraoperative OCT. So sometimes if I'm getting an ICL size of 13, I will also order a 13.5, and I'll have a standby ICL available. And on table, I can decide whether I want to use the 13 or the 13.5 or the 12.5. And sometimes if I get a very low vault on IOCT, I will actually change it to the higher size.
That's a great idea and a great thing that you're doing. What about Sir Dr. Ramamurthy? I think in your slides you mentioned, so you always cross-check with the digital caliper. So that is the gold standard for because all of us and many people, as Dr. Gaurav also said, that there are so many new UBM machines which are not even available in India, and people who don't have high-end machines, they can always switch to digital calipers. So anything that you want to add, Dr. Ramamurthy, regarding the AI tools, or if you are doing something different?
I think, Gaurav said it all. It was a very elaborate and very nice answer. So I don't really have much to add, except for the fact that, initially I was also very excited about this sulcus to sulcus measurement. And basically what I find is when you're using the UBM, as Gaurav also mentioned, you find that the sulcus is not exactly a single point. It's rather an area in the same eye, same observer. If you ask them to measure in 2 different times, it's not a very defined point, and you're unable to replicate the exact sulcus to sulcus measurement. Maybe that's the reason that we most stick on to white to white. And we are also just gaining initial experience. We have the Anterion and the IOL master, and the lasso is some thing that we are hearing about, and we have just started using it. So I really don't want to comment about it because I don't have significant experience on that. But these ways, and based upon the artificial intelligence based formula, might be the way to go. Because even though white to white measured with the calipers, with the something like a device like a pentacam, or often coincide and work very well. Very often, even not very often, occasionally you come across surprises. You think everything is right, but then the watt is low or a little high. So there are factors beyond what is presently being taken into consideration that are acting. And lens size is another consideration that I'm seriously looking into, and that's something that's easily measurable on my anterior. And just in case there's a positive lens size, then I make sure that it's 2.8 or more. And if it's negative, that is, it's below the level of the plane of the iris, then maybe I'd compromise and go on to even a 2.7 millimeters.
And another thing that you mentioned, sir, like because you've been using different phakic lenses like biotech, IPCL, and all of them. So the good advantage of using IPCL is that they have a larger inventory. Like in ICL, there is a difference of 0.5, whereas in IPCL, you mentioned that there are the difference is only 0.25. So you've got a more room and less chances of vault surprise. So, Dr. Gaurav, how often do you get vault surprise? Like, because you've been using different brands of phakic lenses. So, what's your take on that?
So frankly, the surprises do happen. I mean, the good thing is now that, for example, I've started also using the biotech acryl phakic lenses. They have incorporated predicted vault into their calculations. So when I get a calculation sheet from them, they will actually tell you for that particular size what will be the predicted vault. And if you want to use the higher or the lower vault, for example, if you want to do toric ICLs, then you want to stay with a slightly higher. And I would rather stay with a slightly higher vault, like maybe 700 or so, rather than a lower vault, which is about 250 or something. So 500 is great, but it's very, very often you won't achieve 500. So I'm usually, if I'm doing a toric ICL, I will try to aim for like a 700 or something, because then I know that over time, almost every year, you'll lose about 20 microns of the vault as well, because of increasing lens thickness and other factors, right? So I don't want ICL rotation, especially with high astigmatism. And I do get occasional surprises. And then luckily, because I also have the intraoperative OCT, if I have a very low vault, I will sometimes, explant the ICL right then and order a new one. But off late, like last few months, I ordered two sizes and always keep the second one handy to increase the vault if I have to.
Yeah, I think that's a very great idea which you have shared. Like, so, and what about, there is one more thing which I wanted to ask Dr. Gaurav, like, which viscoelastic do you use when you are doing an
I
ICL?
think you read my mind. I was so impressed with Dr. Ramamurthy's technique. I mean, he's not even washing the chamber, and we keep, I actually abandoned viscoelastic almost 5, 6 years back. So I don't use any viscoelastic. I do a hydroimplantation, which is not recommended for beginner surgeons at all. It's only once you have become very proficient, because you tend to have such situations where, which viscoelastic is really useful inside the eye, and you should be fully prepared to inject viscoelastic. So I will stick to saying that viscoelastic is great. And what was traditionally kind of suggested by Star was to use HPMC. But many surgeons kind of started using sodium hyaluronate, like Sir showed. And he showed such an amazing thing, because yes, it does come out as a bolus and the chances of retaining it are so small. And I think he's saving so much time, and also making sure that there is complete removal just by doing that, wash, which he's not even using the bimanual to do that. So I'm so impressed by that new technique. It looks good. The only thing I would here point out, sir, is that when you mention again a very valid point that you don't dilate the pupil, and for that inadvertent injury with the angle with the MVR. So I realized that in that first case which you showed, that was a straight MVR, but in the second case you showed, it was an angled MVR, and and I
Whatever
feel
the
that we
reflector gives me.
should not use either. Off late I'm using side port knives which are calibrated, and also they are very short. So they cannot go beyond like 2 or 3 millimeters, and they are parallel to the iris plane. They are angled. So, and also they are not sharp on the sides. They are only sharp at the tip, right? So they will penetrate. They will not move to the side. So they will not allow you to enlarge the incision, and they cannot go beyond like 3 mm. So very little chance that they'll go and hit the lens. But I think your technique looks great, and dilating the pupil looked so beautiful, and I have done it a few times myself as well. I think I will start doing that in future too.
Oh, I also went through hydroimplantation, and as for most of us, most of the intraocular lenses we do hydroimplantation. So I thought, why not this? But then I find that that's a little uncontrolled, and in phakic intraocular lenses, you want to do as gentle a surgery as possible. So I find that using a high molecular weight cohesive viscoelastic, just hydrating the wounds, entire thing flows out. And of course, both you and Tushia are great votaries of side port incisions and the instrumentation that you have. So I have not really graduated to that level. So I point well taken, Gaurav.
But I'm definitely gonna incorporate the use of visco cohesive, because what I do is I spend like a minute more in taking out the visco. So that's the thing. But with this technique of yours, like it's gonna save so much of time.
And
That
it's not just taking out the visco, which takes time, Tushar. It's also that in spite of what you might do, you will not get complete removal and you'll get IOP spikes, which is why I stopped using visco, the HPMC. Because, if once you do away with the HPMC at least, you have no IOP spikes post-op. And so with hydroimplantation, that was the reason I switched to hydroimplantation. But frankly, with sodium hyaluronate, I think you're getting complete removal anyway. So unlikely that you'll get an IOP spike. Maybe Sir has done a study or something on that, whether when you switch to sodium hyaluronate, did you stop getting post-op IOP spikes a few hours after surgery?
Oh, frankly, we have not done a study, but what we have found is that it's crystal clear corneas and hardly ever come across a raise in intraocular pressure. I mean, I'm all for using Indian, things manufactured in India, very widely use them, just like the phakic lenses also. But one point I want to emphasize is that when you use the sodium hyaluronate, which is manufactured in India, at least a couple of brands that I use, the flow was not as complete as the just by the irrigation. So basically, this is one place where there's a significant expenditure, but then I use Helon GV, and that seems to come out completely. That doesn't happen with the other products.
So, sir, as Dr. Ramamurthy sir was saying that he usually his indications for phakic lenses is mostly on the higher side of myopia, 5 to 6 or above. What about Dr. Gaurav sir? Like, what's your take on that? What are your indications? Uh, so are you going for low myopes also?
Yeah. So I initially, of course, we were also doing like more than -8 and all, and then more than -6 and all. But today, actually, I don't use any cutoff for using an ICL. I quite often do an ICL even for 2, 3 diopters of myopia if the cornea is looking. And I'm sure Sir also does it. He didn't incorporate it in his slides. But he also probably would be doing, if it's a suspect cornea, thin cornea, which does not merit a laser correction anyway, even with a small part, I will not hesitate to use a small part ICL at all. And I think all of us who are doing phakic lenses will agree that, now with the availability of lower power, our threshold of switching to ICLs has really, really changed. I was remembering the times, I sometimes get my post-ops from like 20 years back. And I was, those days we would do corrections of like -12 and -13 comfortably. And, those patients continue to do extremely well today also. And it's not as if, we saw a huge number of ectasias from those. But then the quality of vision obviously would not be great, because then we were probably using like 5.5 optical zones. Otherwise, you wouldn't achieve that higher correction. And now today, I would never go down below 6 because now we don't see too many halos and glares and all. And ICLs definitely with high corrections give much less visual symptoms than a laser correction done for high corrections also. So I think our threshold has really changed. And what probably has made the biggest change is the center flow, which was introduced, because the moment center flow came, our incidence of cataract and incidence of pupillary blocks and everything went away, and our tolerance for low and high vaults kind of completely changed. So today, sometimes if I have a vault which is almost 1 millimeter with a good AC depth, I will not do anything for that patient and put him on watch. Similarly, if I have a low vault in a spherical ICL of say 200 or something, I will again probably not intervene and do anything for that patient either. So I think that's how it looks to me.
I
So,
think
what is
this
the cutoff
very
for?
important. No, sorry. I
Sorry,
mean,
sorry.
just
No, no, please.
re-emphasize something Gaurav brought up. It's extremely important. Earlier we used to think 250 to 750 microns. Anything less or more is something you need to be extremely worried about. I have patients with 80 microns, 100 micron vault with crystal clear anterior capsule. I don't do anything about it. And I did not emphasize it during my presentation, but we also make an angle measurement. And invariably, when you introduce a phakic intraocular lens, the angle narrows down by about 10 to 15 degrees. So in case we are starting out with a angle which is less than 30 degrees, I make sure the vault is not too high. That is, I'll go, if at all I have a choice, I'll go 0.25 millimeters less. But in case it's a wide open angle, then it would be, I'll choose something 0.25 millimeters more. I don't have the ASOCD like Gaurav, so I'm not able to judge it exactly on the table. This is a small nuance that I use, and I think we need to look at the angle also when we are deciding on the sizing.
Absolutely. In fact, it's the angle which is more important than anything else post-op if you're wanting to, your vault is too high for the eye to tolerate it.
And if there is excess vaulting, as Gaurav said, if it's 750, 800 microns, the angles are wide open, there's no crowding, we'll still watch. But if the angles are getting narrowed down 10 degrees, 15 degrees, there is excessive pigmentation there, this is a definite indication for an exchange. You do not wait for them to zip up.
Absolutely.
So thank you. I think Dr. Garvita, you can. It's 9. You said like.
Sir, we have like three questions from our audience. One is from YouTube. The question is, does central hole in ICL create any abrasion in the eye?
Tushya, you can answer that.
Clear and halos, which we explain to the patients beforehand only. So it's just that the patients get neuroadapted to it, and they don't have to look for it, and gradually they don't complain. So that's one thing. That's a very good question. And anything Dr. Gaurav or Dr. Ramamurthy would like to add on that?
No, I think, this was a concern. And Kimiya Shunzu came up with this concept of a central hole. Initially, they tried peripheral holes, etc. They thought if you have a central hole, that might form glare and halos. That's why they hit upon the size of 360 microns. And it's well proven that the size, this size allows enough inflow of exchange of fluid from behind the lens to in front. At the same time, it does not have any cause any dysphotopsia. And glare and halos, it's well proven both on bench studies as well as on clinical experience that it does not really cause a problem.
Right, sir. Two more questions. Is your experience, sir, and outcomes with Viva ICL for presbyopic correction?
You want to take that, Gaurav?
So I have no experience, so I will not be able to say anything on that.
I have actually been implanted quite a few trifocal phakic intraocular lenses from the CAG group, and reasonably good experience, good outcomes with that. And they come with a basic power. The toric version is also available. It's only the central 3 millimeters which has the trifocality, and it can be 1.5 to 3.5 diopters is the range. And you get about, if you implant a 3 diopter lens, you get about 1.2 diopters for intermediate and about 2.1 millimeter diopters for near. And for a 50-year-old or a 45-year-old, I think it works quite well. And we have, it's not something we actively propagate, but at the same time, the patient is very keen and not a candidate for monovision, then we go ahead and implanted this patient. And we have done about 26 cases so far. And surprisingly, we are thinking whether glare halos, because we all know that dysphotopsia is a problem with trifocality or multifocality, is not complained of these patients. When I got back to the manufacturers, they say it's because the diffractive rings are limited to the central 3 millimeters. But practical experience tells me that we have to have a deeper look into it. The Viva lenses is more on a EDOF concept. And I have just done one pair of these lenses simply because, the indication itself is quite low in the sense they want patients beyond 45, -3 to -7 diopters is what you are supposed to select these cases. And then also the toric version is not available. And essentially being EDOF lenses like our EDOF intraocular lenses, near vision is not that great. They're more for intermediate vision. So I think there are surgeons in India just gathering experience, but it seems to be a good way to go. Maybe a little bit of mix a mini monovision might also work. But that's all. I have very limited experience with this, not only in my hands, but I think the Indian experience itself has been fairly limited. You have used these lenses, Tushya?
No, no, sir.
So in fact, at the ESCRS, I attended a few sessions where this was discussed at length from amongst all the users who had already used fair numbers, and some of them had actually stopped using them because there was mixed reviews. There were quite a few surgeons who felt that it wasn't really doing a great job, and there were others who were feeling that yes, it did a great job. So there were mixed kind of feedbacks that were received. And I did see a huge excitement about the Viva much in the ESCRS recently. I did attend 3-4 sessions where this was discussed. So I'm not sure. I mean, I don't have experience, so I should not actually comment on it.
Right. One last question. If a patient, which should be preferred refractive lens exchange of phakic IOLs in cases where both can be planned in a patient?
No, I have a sort of a less than 40 years, small refractive errors. We go for laser vision correction. Obviously, extreme side refractive error will be faking intraocular lens. Basically, if the patient is beyond 50, especially a hyperopic patient, then definitely it's a clear lens extraction that I go for, because there are good trifocal lenses and other similar lenses that are available. But in case the patient is a myope, then to me, clear lens extraction is an absolute no-no. I'll wait for cataracts to develop. So hyperobes +3, +2.5 diopters who require +5 diopters for reading, that's indication for clear lens extraction. Myopes, especially less than 50 or even beyond 50, it will be a phakic intraocular lens if the lens is absolutely clear.
Right, sir. So thank you, sir. They were all our questions that we had from our audience. Thank you for the wonderful class, sir. It was very informative.
Thank you so
Thank
It
you.
was
Thank you so
saying
much.
thank you, Dr. Ramamurthy, sir, and thank you the whole team for putting this up. It was always interesting to meet up again and discuss all these things.
Yeah, you guys are doing a great job. iFocus, bringing in so much of information and which can be readily referred to. I see the array of topics that you're covering. Kudos to you and your team.
It's a big resource which is being built up, actually. It's a very big resource, very useful.
Great.
Thank you, sir.
Thank you. Good night.
Good
Thank
night.
you.
Thank you, sir.
Thanks, Gavita.
Thank
Thanks,
you, sir.
Tushya. Good night.
Thank you, sir.
Bye. All.